All right. Hello and good afternoon, everyone, and welcome to another special episode, shall we say, of Mrftt HIV SCI Echo with Dr. Chris Behrens, who is joining us from the University of Washington, in Seattle, Washington. So this is a topic that I really thought we needed to have a conversation about, because one of the issues we are facing increasingly now with COVID and everything else is that we've been managing some of our patients in whom we've accustomed getting resistance testing and being sure that our treatment is at least closer to being laser focused with the availability of those tests. But as we haven't had access for at least 2 years now, and some of our patients are coming in with what we suspect to be more complicated resistance profiles. Persons who, for example, would be switching from second to third, and persons who are persistently viremic. Is this poor adherence? Is this treatment failure? What do we do? Let's say when we're stopping out on azanavir, do we need to put them on raltegravir or do we need to put them on something? And I think there's been so much conflict around, I won't say conflict, but discussion regarding some of the cases that we've had, that we really welcome a global view on what the data and what the research says about how we should consider migration between and among different treatment lines with respect to antiretroviral therapy. So again, I want to welcome Dr. Chris Behrens, who has a wealth of expertise in this area, and we know we're going to learn a lot, and hopefully we'll be able to apply what we learn in these sessions, in this session, to the patients we take care of. So Dr. Behrens, thank you again for the benefit of your time and your experience, and I'll turn the floor over to you.
Sure. Thank you very much, Dr. Boyce. It's always a pleasure to join your group and give some presentations. So yes, I'm going to talk about managing treatment failure in the absence of resistance testing and try to use an evidence-based approach where possible. We have the usual acknowledgement of our sponsors and funders. I have no relevant financial disclosures. Our learning objectives are these. Hopefully you will be able to summarize some recent evidence regarding empiric second-line ART for people failing a typical first-line regimen, describe approaches to designing treatments for failure of second-line treatment regimens as well, and discuss implications for Trinidad and perhaps the broader Caribbean region. So just a few definitions so we're all on the same page. When we say treatment failure, we really are referring to the HIV medications no longer working due to resistance. Treatment failure due to people simply not taking their medications in the presence of a wild type virus, that technically we don't really consider that treatment failure because the meds are still active. It's simply that they're not taking them for whatever reason. So just to be clear, for the purpose of this talk, when we are talking about treatment failure, it implies that there is resistance among the strain of HIV that's compromising the ability of these medications to work. First-line antiretroviral therapy refers to the initial choice of treatment. There's usually a preferred and an alternative first-line ART options that are out there. Second-line ART is what you turn to when first-line treatment fails. Again, presumably, if not proven, due to resistance. And again, there are typically preferred and alternative second-line ART regimens. And consequently, third-line ART, to follow the terminology, what you choose when your second-line treatment fails, again, presumably due to resistance. You may hear the term salvage antiretroviral therapy. That sort of refers to people who are at third line or beyond who have highly resistant virus, and we're really trying to figure out a way to manage these individuals. So let's briefly review, how do we get to antiretroviral drug resistance in the first place? Well, this really is fundamentally the same phenomenon that occurs with bacterial pathogens and antibiotics used to treat those infections. But with HIV, the whole process is sped up dramatically because there's such a high replication rate for HIV, and because, as we will soon see, HIV makes a lot of mistakes and generates a very high frequency of mutations because the key enzyme involved is highly error prone. That key enzyme is shown here. This is HIV reverse transcriptase. Its job is to take the HIV RNA that enters the cell in the first stage of the HIV life cycle and translate it into DNA. And HIV reverse transcriptase, as I mentioned, is an enzyme that makes a lot of mistakes. It's highly error prone. So when it is drawing nucleotide analogs or nucleotides from the host cell to add to the growing chain of DNA, it often puts in the wrong nucleotide. About 1 in every 5,000 to 7,000 nucleotides is incorrect. And for a polymerase enzyme, that's actually a very high error rate. There's no proofreading mechanism either to correct it, which is different from our usual cells. As a consequence, these mutations can develop because when you substitute the wrong nucleotide into the growing DNA chain at the top, that will ultimately result in often putting a different amino acid into the growing protein chain that's being encoded. Sometimes the different amino acid that's placed as a consequence of the wrong base pair being generated by reverse transcriptase results in a key change in the structure and hence the activity of that enzyme. So in this example, there has been an error in the base pair generation of HIV DNA that subsequently corresponds to a different amino acid being generated at position 103 in the HIV gene that codes for that very same enzyme, HIV reverse transcriptase. And the mistake that's been made results in an HIV strain that is not affected by non-nucleoside reverse transcriptase inhibitors like efavirenz or nevirapine. Ordinarily, those drugs act on this very enzyme, HIV reverse transcriptase, but as a consequence of this mutation, those drugs are ineffective. The enzyme is immune, as it were, to the effects of those medications. The terminology we use for this specific mutation is K103N, where 103, the number, refers to the codon number. K is the wild type amino acid normally found at that position, and N corresponds to the amino acid that has been substituted as a consequence of the mutation, in this case, asparagine. So through quite a bit of research and experience with HIV, we have identified the signature mutations that tend to develop in people who are failing treatment with various HIV medications, and we've been able to establish exactly what the implications are of those mutations. So here I've summarized the key ones that are relevant for an individual failing a typical first-line regimen that has historically been often used of an NNRTI-based regimen that consists of either efavirenz or nevirapine, paired with either 3TC or FTC, paired with either AZT or tenofovir. And what we see in individuals who are failing a treatment regimen like that is the rapid evolution of mutations to the NNRTI, efavirenz or nevirapine, by way of either the K103N mutation that I just showed you, or a similar mutation, Y181C. Again, these develop rapidly and confer very high-level resistance to efavirenz and nevirapine. With respect to some of the second generation or later NNRTIs, the resistance profile may be variable. Similarly, we see in individuals failing this treatment regimen, the rapid development of the mutation M184V or M184I, This is a mutation that confers high-level resistance to 3TC and FTC. It can confer some low-level resistance to abacavir, especially in the presence of other mutations. But interestingly, it increases susceptibility to AZT, tenofovir, and D4T. Sorry, slide switched. And it furthermore, it impairs HIV replicative capacity. HIV is, you can think of it as being hobbled by this mutation, and it doesn't replicate as well if it has to carry this mutation. In individuals failing a treatment regimen like this, the mutations to the AZT or the TDF tend to develop more slowly and by different pathways. Resistance to AZT usually occurs as a consequence of the evolution of one or more what we call thymidine analog mutations. These include M41L, D67N, K70R, et cetera, et cetera. These emerge gradually. They promote resistance to AZT as well as D4T and abacavir, and essentially, the more mutations you have, the more resistance there is. You generally do not get significant resistance to tenofovir as a consequence of these until and unless you have multiple thymidine analog mutations. Now, individuals failing TDF-based treatment, they generally experience or develop the K65R or N mutation and or K70E or G mutations. Again, these tend to evolve a bit more slowly, and they confer intermediate to high-level resistance to tenofovir, DDI, abacavir, and D4T. Excuse me one second. But interestingly, increase the susceptibility to AZT. So you have a couple of mutations here that actually seem to create a bit of hypersusceptibility to other agents, which has interesting implications for our next treatment design. So the implications of these findings are as follows. Since virologic treatment failure is predictably associated with nearly universal high-level resistance to efavirenz, nevirapine, and 3TC or FTC, whereas resistance to tenofovir AZT may or may not exist. It can be absent, low level, or high level. So for these reasons, the WHO and many other groups have therefore recommended for second-line treatments, when we don't have resistance testing, that one should replace the efavirenz or nevirapine with either dolutegravir or a boosted protease inhibitor, such as darunavir. And one should continue the 3TC or the FTC due to the indirect effects of that signature M184V mutation, both on HIV viral fitness and susceptibility to other NRTIs, such as tenofovir and AZT. And one should substitute AZT for TDF or TDF for AZT, depending on which was used in the first-line regimen. So if your first-line regimen was AZT-based, then substitute tenofovir. If your first-line regimen was TDF-based, substitute AZT. And this is a sample, a representation of exactly what those WHO guidelines suggest, if you're familiar with what those guidelines look like. And here I'm focusing specifically on a typical first-line regimen of 2 NRTIs plus efavirenz. They say the preferred second-line regimen is 2 NRTIs plus dolutegravir. But you can also use darunavir boosted by ritonavir if available, and if that's somehow preferable. And furthermore, as the sort of red asterisk at the bottom notes, you should always try to optimize the NRTI backbone by switching AZT to TDF and vice versa, depending on what was in your first line regimen. Now, these guidelines, however, raise a few questions. And I think it's important to think about these, and we're going to actually go through and try and answer them. The first question is, do we really need to switch tenofovir to AZT in a second-line treatment regimen in people who are failing first-line treatment that includes tenofovir? Because it's worth noting that AZT isn't as well tolerated than tenofovir. It requires twice-daily dosing. It has potential hematologic side effects. And furthermore, research has shown that AZT is more likely to be discontinued than tenofovir in second-line regimens. Lastly, I would point out that there was a study that came out of Haiti, an observational study that found that actually maybe we don't need to switch the tenofovir to AZT because it didn't seem to help in that observational cohort that they analyzed. The next question is, the guidelines suggest in second-line ART replacing the NNRTI with dolutegravir or a boosted protease inhibitor like darunavir. Does it matter which one? Dolutegravir tends to be more readily available, especially in the fixed-dose TLD combination, than darunavir is. If we could have some confidence that it works just as well as boosted darunavir, that would be helpful. And then the last question is, how much impact do tenofovir or AZT resistance mutations have on the effectiveness of these second-line treatment regimens? So in theory, if there is high-level resistance to tenofovir and or AZT, it could compromise the effectiveness of these second-line treatment regimens. Now, to answer these questions, enter the Nadia study. This was a recently published, very important study that came out of Africa, sub-Saharan Africa, that really aimed to settle some of these very important questions. This was a 2x2 factorial, open label, but randomized non-inferiority trial performed in over 460 patients in sub-Saharan Africa. These were all patients in whom first-line NNRTI-based therapy had failed, as demonstrated by persistent HIV viral load of at least 1,000 copies per milliliter. The resistance assays were performed on each of these patients, but they were not used to guide the allocation of treatment arms. Again, that was random. And it was randomized to, every individual was randomized to one of 4 different arms. And these are the 4 different arms that you can see, over 100 patients in each of the arms. And as you can see by the design of the trial, it was intended to be able to compare dolutegravir versus boosted darunavir, and to compare zidovudine versus tenofovir as options for our second-line treatment regimens. So just to cut straight to the results, in terms of comparing the performance of tenofovir versus AZT or zidovudine, the 2 agents performed essentially equally well in terms of how they did in second-line regimens. Slightly higher efficacy of tenofovir, but that was not statistically significant. If you subanalyze by, who among those received dolutegravir versus darunavir, again, you saw no significant difference. It was essentially the same. Maybe a slight benefit of tenofovir over zidovudine, but not statistically significant, no matter how you look at the data. Now, they even looked at other subgroup analyses to try and see, was there any situation in which it made a difference whether you picked AZT or tenofovir for your second-line regimen in these individuals. And in none of them did it make a difference. But what's really striking about these findings, and which I've sort of outlined in the red box there, is that not even the amount of tenofovir resistance made a difference. So individuals who were predicted to have high-level resistance to tenofovir, but who were given tenofovir anyway in their second-line treatment regimen, they still did just as well on tenofovir, if not better, than those individuals who received AZT. So this is kind of a surprising finding, because it just kind of goes against the grain of the theory and everything we had thought we knew about how HIV resistance works. Now, moving on to some of the other primary outcomes. What about dolutegravir versus darunavir? Does it matter which of those anchor drugs, so to speak, that you use in your second-line empirically designed treatment regimen? And in this trial, it did not. The two performed essentially equally well, no statistically significant difference between outcomes among those two groups. Over 90% achieved virologic suppression, regardless of which was used. Again, if you sub-analyze by those who received tenofovir versus zidovudine, didn't seem to matter. And if you further substratify by different subgroups, again, no matter how you try to analyze the data, you just don't really see a significant difference between the two in any of the key variables. I think what's really kind of striking, though, is just how well people did overall on these empirically designed treatment regimens for second-line therapy, regardless of which regimen they received. And despite the fact that, for example, individuals who are predicted, according to their resistance testing, to have no active NRTIs, right? Even those individuals enjoyed over 90% rates of virologic suppression on that second-line treatment regimen, even though it was predicted on resistance assay results, again, that neither the tenofovir nor the AZT nor the 3TC or FTC should have any efficacy. So this is kind of a dramatic finding, and I think it sort of shakes up the reasoning a bit and the findings that should drive changes in our treatment guidelines. So, but first, let's go back to the three questions I posed earlier. So the first question is, switching from tenofovir to AZT in second-line ART really necessary for those individuals whose first-line regimen that failed included tenofovir? And I think the answer very clearly from this trial is no, it does not. Tenofovir performs equally well, even in patients for whom tenofovir was predicted to have no activity whatsoever in their second-line regimen. The second question is, does the choice of dolutegravir versus boosted darunavir really matter in second-line treatment? And the answer, again, is no, because these two agents performed absolutely equally well, no matter how you analyze the data. So pick whichever is easiest and most available according to your program, and of course, according to what would work for your patient. And the question 3, how much impact do the tenofovir and AZT resistance mutations have on the effectiveness of these second-line treatment regimens? Because again, in theory, the more resistance you have to one or both of those agents, the more it should, at least in theory, undercut the effectiveness of the regimes. But in fact, it did not. People seem to do very well despite having very high level resistance to these agents based on their resistance assays. So I think there are certain implications of that trial for future guidelines that the WHO has not really gone there yet. I think it's, this trial was just published a few months ago, and they have not updated their guidelines yet to reflect it, but I do suspect that we will see changes in their guidelines upcoming, and I think the guidelines probably will and should look something like this. So the empirically designed second-line ART for individuals failing a typical first-line treatment regimen of tenofovir AZT plus 3TC or FTC plus efavirenz or nevirapine should really consist of tenofovir or AZT or abacavir, doesn't matter which, take your pick, combined with 3TC or FTC, combined with dolutegravir or a boosted protease inhibitor, ideally dolutegravir. And again, either tenofovir or AZT or abacavir for that matter should work equally well, regardless of which agent was used in the first line regimen. There's no need to swap one for the other. Really, the choice depends upon variables like patient tolerability, preference, ease of dosing, et cetera. And I think for most individuals, it's really going to be tenofovir. Now, abacavir was not formally evaluated by the Nadia trial, but it's likely to work just as well as tenofovir or AZT, and so I think that should remain an option. 3TC or FTC should be continued in the second line regimen. Yes, there's high level resistance that's almost certainly going to be there. However, there are these ancillary indirect benefits of keeping 3TC on board because it forces HIV to maintain that M184V mutation that both hobbles the virus, gives it less replicative capacity, and at the same time sensitizes it a bit to other nucleoside analogs like tenofovir or AZT. If a boosted protease inhibitor is selected as the anchor drug for your second line regimen, evidence to date supports boosted darunavir as the ideal choice. The Nadia trial did not formally evaluate boosted atazanavir or boosted lopinavir, for example. Those boosted PIs are also very potent there. And honestly, it would not surprise me much if those turn out to be just as effective as darunavir. Now, we do know that, boosted darunavir really is the ideal protease inhibitor for treating HIV. It has very high tolerability as well as the highest potency. And it has the highest genetic barrier to resistance as well. So it really hits all three variables very highly and probably better than any other protease inhibitor out there. But lopinavir and atazanavir, as long as they're boosted by ritonavir, they do fairly well also. And so I think it's very reasonable to consider using those if you don't have boosted darunavir available. Now, I've spent a lot of time talking about the design of second-line treatment for people who fail efavirenz or nevirapine-based first-line ART. What if that first-line regimen was based on dolutegravir? Well, this is where we are with those WHO guidelines again. And the guidelines reasonably suggest use 2 NRTIs, but substitute for dolutegravir a boosted protease inhibitor, such as atazanavir or lopinavir, or boosted ritonavir, and maybe even keep the dolutegravir on board. You may or may not have the NRTIs on board according to these WHO guidelines, but the WHO guidelines, of course, still favor the optimizing the backbone by making the substitution. Now, personally, I think based on the Nadia trial, I don't think we need to worry about, switching the nucleosides around the way these guidelines recommend. I think it's pretty clear that it doesn't matter that much what your NRTI backbone looks like, so long as it includes tenofovir or AZT or abacavir, and it includes 3TC or FTC. Again, boosted darunavir looks like the best option, but probably the boosted protease inhibitors atazanavir and lopinavir may work well enough as well. Now, what about the design of a third-line ART regimen following failure of second-line treatment failure? We don't have, unfortunately, a high-quality clinical trial like the Nadia trial to guide us in this situation. And in fact, it really is quite difficult to sort of empirically design a treatment regimen for this situation, because by the time you get to failure of a second-line regimen, you've probably got a fair amount of resistance that's built up. You've got some limited options, and it's going to be super helpful to know exactly what kind of virus you're dealing with so that you can most wisely select among your antiretroviral options in terms of designing the most effective third-line regimen possible. The WHO guidelines don't really go there in terms of providing guidance about designing third-line regimens. They sort of have this vague alternative second-line regimen description, which the language to me sounds like it overlaps a bit with possible third-line description. So we don't get a whole lot of guidance from the WHO on this crucial question. The Jamaica guidelines that are, very recently drafted and soon to be published, I thought I would cite them because they have some language in there that I do think is relevant. And apologies, I don't know exactly what the latest Trinidad guidelines say on this point, but in terms of regional guidelines, the Jamaica guidelines suggest for third-line therapy, there are these guiding principles, and one of which is do resistance testing, guide your treatment on resistance testing, because it's otherwise you really are kind of flying blind here. In Jamaica, these are the main drugs they have available to them in the use for use in third-line regimens: boosted darunavir, etravirine, and raltegravir. And I think these are good options. I think dolutegravir should also be retained as use in third-line treatment regimens as well. I think the presumption was that dolutegravir, having been already used so far in either first or second-line regimen, would not be as good an option. However, the fact is, when people fail dolutegravir, we often do not see dolutegravir resistance. And I think you can make a solid argument that perhaps dolutegravir should be continued in third-line treatment, even if it was a component of a prior first or second-line regimen. Darunavir, I've already talked about how just how potent and well tolerated and what a high genetic barrier to resistance it is. So I really think this is kind of one of the best options out there for treating resistant virus. It's very difficult for HIV to develop resistance to it. And again, it's very well tolerated. It can be dosed once daily as well. So there again, there's darunavir at really the top of our chart along both axes of potency and genetic barrier, as well as tolerability. Etravirine, I think this was a very sensible inclusion by Jamaica in their treatment options, because this is a second generation or later generation non-nucleoside reverse transcriptase inhibitor that commonly will work despite the presence of K103N or Y181C mutations. So even if individuals have failed efavirenz or nevirapine in the past, etravirine is likely to still work for them, or at least provide some potency. There are the reason being that the mutation patterns that are responsible for etravirine resistance, which are in the sort of red box there, they only incompletely overlap with the ones associated with nevirapine and efavirenz. So again, the K103N doesn't confer resistance. The Y181C does confer some resistance. There is a way to sort of look if you have a resistance assay, and this is why it is so important to get that resistance assay. If you have the specific mutations you know that are present, then you can essentially come up with an estimate of just how effective the etravirine might be in your next regimen. And then circling back to dolutegravir in third-line regimens, it's worth noting that this drug has a very high genetic barrier to resistance. In individuals who fail dolutegravir-based ART, we typically do not see resistance to that agent. So dolutegravir is very likely to retain activity even if the patient has failed treatment containing that drug, and could therefore be a useful component of third-line regimens. However, it should be kept in mind that if you're going to use dolutegravir in third-line ART, it should be dosed at the twice daily, 50 milligrams twice daily, if this patient has ever received any integrase inhibitor in the past as part of a failing regimen, whether that be dolutegravir or raltegravir, just to be safe. So we don't have nearly as much evidence, of course, in these situations, but these are just some of the guiding principles that I want to put out there. And I think at this point, I'll open it up to discussion and questions.
Thank you, Dr. Behrens. That was very revealing, as I expected it would be, because, you know, the maxim that we were always taught about never change just one drug in a failing regimen, and you have to have at least 2 fully active drugs. I think, given these sort of regimens where we're seeing 2 drug therapy, and given some of the data that came out with, I think, some of the foundational, like 3D and dolutegravir studies, where even if you have an M184, you're still suppressing. So I think the hints were leaking out bit by bit that we don't know all that, we don't know as much as we think we do about how, as you said, drug resistance works and how a suppressive regimen can be constructed, especially with modern potent agents. So again, thank you very much for that. And I'll open up the floor to anyone who has any questions for Dr. Behrens.
I think that was a very good way of putting it, Dr. Boyce, that we don't know as much as we think we do. And that crops up repeatedly when we, in our studies of HIV. We think we know that, you know, you can and you should and should not do this in treating second line and designing your second line regimen. And then we do the actual clinical trial and it turns out, well, wait a minute, there's something off in our theoretical reasoning here.
I wonder if I could ask a question. This has come up in clinical practice. So we had a situation where we had a stock out of atazanavir for several months, and you know, the majority of our patients on second-line boosted PR regimens are on atazanavir. Patients prefer it. It's once daily. They have fewer GI side effects than lopinavir or ritonavir. So when we stocked out, you know, we kind of switched a lot of patients to lopinavir or ritonavir, and quite a few of them just couldn't tolerate it. The pill burden was too much. The GI side effects were too much. And darunavir, ritonavir is in relatively limited supply because it's third line. So one of the questions we had was, well, can we put them on raltegravir? And I think there were 2 conflicting studies about whether or not raltegravir can be used as a second-line agent. I think we just decided it's not, it's given the backbone is compromised, and we don't have the data to show that raltegravir can be used in that context, that it might not be a good idea. But I mean, is there anything that can guide us there, or even just empirically, as opposed to just the actual data?
Right, very good question. And let me see, I have some, I think I have some information about raltegravir that I could share as well. But it's true. When it comes to using raltegravir in second-line treatment regimen, it's a little bit of an evidence-free zone because we don't have anything like the Nadia trial to guide us. And raltegravir is not quite as potent, not quite as high a genetic barrier to resistance. However, it is a very good medication, and it is from an entirely new drug class for people who are failing first line. So you can kind of argue it both ways. Let me, there we go. Let me just share this. This is some sort of what we know, some stuff we know about raltegravir. It has been used in treatment-experienced patients who did not have any integrase resistance. And I remember, raltegravir came out before dolutegravir, and it was very wide. We used it very widely and commonly in people failing an NNRTI-based initial regimen. And I remember there, I don't have memories of people failing it, to be perfectly honest. Basically, I remember my recollection, at least in my clinic and personal experiences, of continuing patients on this agent until dolutegravir came along and was, a bit better, and just once daily dosing. Although we've since discovered you can dose raltegravir at once daily, but we generally transition people to dolutegravir because it had this better profile. But I think raltegravir makes a perfect sense as a second-line agent. You do have this concern, that it's not quite as strong an anchor, as dolutegravir, and it might not be quite as strong an anchor as a boosted protease inhibitor. But if you, for example, have a stockout like you described, I think raltegravir is a perfectly reasonable option to go with. The one thing you have to be careful of is that if your raltegravir fails, then, sorry, I was trying to advance this slide. If that patient on raltegravir experiences treatment failure, over time, more and more mutations accrue that can start to compromise the effectiveness of dolutegravir down the line. Okay, so people failing dolutegravir, if they've never seen dolutegravir before, they very rarely evolve resistance to it. However, you can create dolutegravir resistance in somebody by giving them raltegravir and having them fail that raltegravir-based regimen and fail it for several months of time. Then they can accumulate enough resistance mutations that they have now evolved resistance to dolutegravir, and dolutegravir may not work so well. So that's another note of caution, I would say.
Dr. Seaver, I saw you had your hand up. You still have a question?
I'm toying with the question, but I'll ask it anyway. Afternoon, everyone. My question was with respect to patients on Truvada. You said if they go into second line, we don't necessarily have to change that one out, and that it may be the same with abacavir. I don't. Do we? I'm just kind of struggling with the abacavir one, then wondering, because I'm struggling at this time, wondering for patients who are on abacavir, 3TC, efavirenz, if they have to empirically switch. Are we seeing then that we can just switch out the efavirenz and maintain the abacavir 3TC backbone?
I think that's likely. That's probably what I would do if this is a patient for whom tenofovir is not an option. I think the implied lesson from the Nadia trial, even though it didn't include specifically abacavir, is that the composition of your NRTI backbone doesn't matter that much, so long as we include 3TC or FTC, again, so we force HIV to keep that 184V mutation. And as long as we pair that with another nucleoside reverse transcriptase inhibitor, and I think it probably doesn't matter much, just based, and now I'm basing more on theory, it probably doesn't matter much whether that's abacavir, tenofovir, or AZT. Basically because in the Nadia trial, it was very clear, it made no difference whatsoever whether you went with tenofovir or AZT, and it made no difference even if you looked at how many, at the resistance profiles, which even if the resistance profile really favored AZT, that AZT did not perform any better than tenofovir in that setting. So I imagine the same thing, the same principle. I can't see why that would not hold as well for abacavir. Hence, sure, keep the abacavir on board in patients who are failing first-line regimen that includes abacavir and 3-TC, and for whom tenofovir is not an option.
Thank you.
Dr. Boyce, I think Trinidad, I think the MRF should sponsor a Nadia 2 trial that includes an abacavir arm, so we can better answer that question. Are you up for that?
So one of the interesting things that, I mean, we've been doing resistance testing, I think, since 2008. And one of the things I realized that a lot of patients who fail first line have just an M184 and a K103. And it's essentially just switching to one drug, right? So it would be very interesting because if we even just that compiled data, thousands of resistance tests, we can just going through that, I think, can be predictive in terms of time course, in terms of accumulation of medications based on some of the older drugs and some of the previous regimens. And so there's some historical perspective. I remember we used to speak to warm line early on, and we had patients really, really complicated, like 3 times and M184, and essentially high level resistance to everything. And the thinking then was put them on as many nucleosides as they can tolerate. So we had patients like 4 nucleosides and a boosted protease inhibitor. And essentially all of them now simplified to 2 nucleosides, but maybe with an integrase and a CPI. So it would be interesting about the abacavir issue, because a lot of that not polypharmacy, but that 4 and 5 drug therapy regimens drove people out of care because it's difficult and it's unpleasant and it's a lot of drugs and a lot of side effects. So that might be very helpful, actually.
Yeah, and it brings back memories I have too, also of having managing patients who had high level drug resistance to all our available agents, and basically we'd sort of like try throwing everything at them, on the theory that, well, hopefully something will stick in terms of having some direct effectiveness, and if not that, by forcing HIV to carry mutations to all these drugs at once, it might hobble the virus so much that it can sort of barely replicate. And I mean, that works. I think we probably saw some success with some patients, but it could be so toxic that you could have the disastrous outcome of driving people out of care with that. So I think another interesting thing about the Nadia trial is that just having 2 NRTIs on board, one of them being FTC 3TC and the other being more conventional NRTIs, is probably enough to force HIV to maintain enough resistance mutations, as long as you couple it with a highly potent anchor drug, third drug. So I think the whole idea of just showering them with a whole bunch of drugs at once is no longer in favor for the most part.
So I don't want to talk too much, but I don't see anybody else asking questions. So this question has always sort of been in the back of my mind when we're dealing with patients who are, not virally suppressed, especially those, not especially, but particularly those who are not suppressing because of adherence issues for whatever reason. And one of the questions I always have, and I think I would have brought it up at the Caribbean Echo with one of our cases, that tension between migrating to another treatment line, knowing that you haven't solved the underlying adherence problem, in which case they're likely to be poor adherent to that treatment line anyway, and maybe pick up mutations to those new drugs, as opposed to keeping them on the older regimen, knowing that they're not adherent, knowing that they may acquire more mutations, but if we don't solve the adherence problem, then migrating them makes no sense, because we were just essentially, shifting chairs and decking the Titanic without actually fixing the underlying problem. I wonder if I get your insight and your experience with that sort of problem.
Right, and I would say it's even worse than, in your analogy, it's even a little bit more than shifting chairs, because you're burning chairs in the process too, potentially. Because if you take someone who's has resistance already and is failing with adherence problems to boot, and then you make a change, if they continue to be non-adherent, you risk them promptly evolving resistance to the new drugs, and then you start losing more and more options. You start burning more and more of your options down the line. So the sort of conventional thinking and teaching on this topic is solve the adherence problems first, then make your switch to second, third, or whatever your line, your next regimen is going to be, because otherwise you're unlikely to get any traction. You may actually make things worse. Now, having said that, that's sort of easy to say and less easy to implement when you're confronting a patient with very advanced HIV disease, very low CD4 counts, who's clearly failing the current treatment regimen. It's hard to guarantee adherence going forward, and that their numbers and their risks of morbidity and mortality aren't going to improve unless you get them on more potent treatments. So sometimes you can't afford to wait until you have guaranteed until the patients have demonstrated good adherence before making that judgment call to switch to a subsequent treatment regimen. So I guess I have to say, thankfully that's a dilemma I don't confront as often anymore since the introduction of dolutegravir. For example, it's really been such a strong anchor drug for so many of my patients. And the ones who continue to do really badly, they're simply not taking the medications at all. And for them, it really is clear that we've got to do something about their adherence and focus on that, because no matter what I'm prescribing them, they're simply not taking it for some reason. So I don't think that's the most satisfactory answer, but that's kind of just an acknowledgement that I struggle with that too. And I don't think there is any really clear-cut answer. We have these principles, but it can be difficult to apply them consistently and know that we're applying them the best way for each and every patient.
Thank you. Dr. Musa, I've seen your hand up.
Thank you. I was just wondering, Dr. Behrens, if you have a patient on second or third line treatment with either dolutegravir or Biktarvy, and you don't have a previous resistance test against integrase inhibitors, and for some reason or the other, you run out of either Biktarvy or dolutegravir, but you have raltegravir, could you switch them to raltegravir for a short time while waiting for the supply of either dolutegravir or Biktarvy?
Yes, in general, I would do that. If they've been doing well on Biktarvy or dolutegravir, then I think substituting raltegravir makes perfect sense. It's not quite as potent and genetically high barrier to resistance, but it's still a very good drug. And clearly, integrase-based therapy is working for that individual. They're tolerating it well. So that's absolutely what I would do.
And the other problem we encounter at Mrftt, there's patients who are very poorly adherent to their treatment. They're on second line, but they have persistent high viral loads. Sometimes the practitioners keep doing viral loads every 1 or 2 months or every 3 months. But my question is, in such a situation, if you have access to resistance testing, how often then should you do resistance testing in somebody who is poorly adherent and has high viral loads for 1 or 2 consecutive years?
Mhm. Well, that's the kind of person for whom resistance testing is clearly indicated. I would want to do it as soon as possible and then modify the regimen based upon those results. And those results will tell you a few things. They may actually undermine your theory about your patient's adherence. Sometimes a resistance assay is an expensive way to establish that your patient is actually not taking their medications, because if you get back a wild type virus with a resistance assay, it's pretty good evidence that they're not actually taking their medications after all. But if, on the other hand, you see, a high resistance to the medications that they're taking, well, then you've got something to work with there. And at that point, you need to, see what your options are and try and construct a regimen that is most likely to work based upon those results, as well as what regimens have been tried and may have failed in the past. There's a bit of an art as well as science to interpreting genotypic resistance tests that relies heavily on the patient's individual history and what they can or cannot take, once or twice daily dosing, for example, food insecurity. So it's not always straightforward, but I would do resistance testing each and every time I have a patient that has high level, or has unsuppressed viral load, despite what I believe to be high level adherence.
No, this is a situation where they have low level adherence. So you do a resistance test and it shows you wild type. You keep them on the same treatment. You do it again, it's wild type. Yeah. So.
Well, yeah, you can you can do as many resistance tests as you like, and it's not going to restore their adherence. And I mean, it's all about trying to establish the right, the rapport with the patient and gathering as much information as you can as to what's the barrier to adherence. And, almost always the patient will know why he or she is not taking those medications. And so it's a question of just trying to get that out of them. And again, that's far more of an art than a science. And you have to rely on interviewing techniques, ancillary sources of information, trying to establish rapport, things like that. It's by no means easy. I mean, I certainly have had patients that I'm clearly non-adherent, and yet every time I saw them, they swore they were taking their meds, and I had excluded things like, you always do have to think about drug interactions or malabsorption, for example. I mean, not all, it's not always non-adherence. It is possible that they have some sort of drug interaction or malabsorption problem that's resulting in very low serum levels of the drug, and that's why you're seeing wild type virus despite them taking the meds. But once you've excluded those possibilities, yeah, it's just a matter of figuring out why they are not taking the medications.
All right, so it's just about 3, so I think we'll call time here. And again, thank you everyone for participating. It was again a fascinating presentation. Thank you again, Dr. Behrens. You're dynamic, electrifying, and so informative as usual. So just want to remind everyone that our next ECHO session is, we're back on Thursdays. Remember, the mental health echo has come to an end, so there's no mental health echo next week, Thursday. Our next MRF HIV STI echo session is the 14th of October, 2020, which is in just about 2 weeks' time. So again, everyone stay safe, stay well, fight the Delta variant, encourage people who care about you and who you care about to get vaccinated. And we shall see you in 2 weeks' time. Again, thanks so much and take care.